Nutrition, Concept 16 from Concepts book. Learning objectives. Define and describe the concept. Notice risk factors that place individuals at risk for nutrition problems. Recognize when an individual is experiencing inadequate nutrition. Provide appropriate nursing and collaborative interventions to optimize nutrition. Nutrition encompasses the process by which food and nutrients affect growth and development, cellular function and repair, health promotion, and disease prevention. As a science, nutrition delineates the requirements as well as the functions of macro and micronutrients for optimal physiologic functioning. Most nutrients are needed on a daily basis to achieve short-term and long-term health goals. Nutritional status impacts a variety of health conditions and disorders. In turn, many diseases adversely affect nutritional status by altering the ability to ingest, digest, absorb, and metabolize nutrients in their intact form or at the cellular level. Because nutrition and health are directly linked, this represents a fundamental concept for nursing practice. Definition. The concept of nutrition is complex, involving a number of physiological processes. For the purpose of this concept presentation, nutrition is defined as the science of optimal cellular metabolism and its impact on health and disease. Several other terms are essential to an understanding of this concept that merit definition. Macronutrients are the kilocalorie, kcals, energy-containing sources of carbohydrates, proteins, and fats. Alcohol also provides kilocalories, but it is not considered a macronutrient because it cannot support or maintain bodily functions. Vitamins and minerals are micronutrients because they are required in minute amounts. Some minerals are needed in such small amounts that they are called ultra-trace mineral requirements. Water is the final product considered to be an essential nutrient. Phytochemicals is a term that refers to plant compounds that have antimicrobial, antioxidant, anti-inflammatory, and immune-boosting properties. Examples of phytochemicals include lutein, L-U-T-E-I-N, associated with the green color of vegetables, and lycopene, found in high amounts in tomato products. Scope. Nutritional status can be viewed as either optimal or suboptimal. An optimal nutritional status is one in which all nutrients are available in balanced amounts for cellular metabolism and physiological function for the individual. A suboptimal state or malnourished state reflects either insufficient or excessive quantity or quality of macronutrients or micronutrients. The scope of this concept is represented as a continuum with malnutrition on both ends, which is insufficient nutrition and excess nutrition, and optimal nutrition in the middle. The continuum representation is important because nutritional status has the potential to change in either direction due to a number of factors and can be corrected with successful measures. Nutritional health status is also an issue of balance or imbalance. Poor nutritional status negatively impacts health, and poor health can negatively impact nutritional status. As you can see from this slide, this is the physiological process and consequences of the digestive system. This is a review of anatomy and physiology, which includes oral intake, digestion, absorption, elimination, cellular metabolism, which then goes to or takes place in the stomach and the intestine, and then does occur after meals, which is called the gastrocolic reflex. And in the stomach, you would have peristalsis, and the sphincter at the end of the rectum would be allowing elimination. Variations in context. Malnutrition is a comprehensive term that refers to two major categories of nutritional conditions: insufficient nutrition and excess nutrition. Within each of these two categories, nutritional problems are represented by the specific nutrient or nutrients involved. The causes of problems vary widely and include problems with access to food, intake, absorption, and metabolism. Insufficient nutrition. Insufficient nutrition occurs when there is inadequate intake. impaired nutrient absorption, or ineffective nutrient utilization occur, leading to a state of malnutrition. The malnutrition can be associated with insufficient calorie intake, leading to unintended weight loss, and/or insufficient intake of one or more nutrients, leading to a number of nutritional deficiencies. The state of being underweight is described as a body mass index (BMI) less than 18.5. Starvation-related malnutrition describes conditions such as anorexia nervosa, whereas acute disease-related malnutrition occurs after burn injury or trauma. The third type of adult malnutrition, chronic disease-related malnutrition, is exemplified by sarcopenic obesity or pancreatic cancer. A number of physiological consequences occur associated with a poor nutritional state on both ends of the spectrum: nutritional deficiencies and nutritional excess. These are best understood by considering the specific nutrients involved. Malnutrition is highly devastating for infants and children because it limits their growth, brain development, ability to learn, and later, their ability to participate effectively in society. Macronutrient deficiencies. Protein is a component of every cell of the body. Thus, protein deficiency has diverse consequences, and the effects can be subtle or dramatic, depending on the severity, amount of inflammation, and length of time. In children, an inadequate intake of protein and kilocalories is called marasmus, which impairs growth and development, stunting height and brain development most evidently. The condition in which the insufficiency is protein alone with adequate energy is called kwashiorkor, Kwashiorkor, and is seen in developing countries after an infant is weaned to a diet that contains mostly grains. At any age, inadequate protein intake will adversely impact the body's ability to repair or replace body tissues or produce other constituents such as immune factors. In older adults, the loss of muscle mass in sarcopenia is difficult to replace. A spiraling decline in health may occur if not corrected through rapid and effective interventions. Insufficient circulating protein in the blood is hypoalbuminemia, can also lead to anarska, which is severe generalized edema, ANASARCA. Inadequate carbohydrate intake can alter cellular metabolism and results in the use of dietary protein as a fuel substrate, diminishing cell growth and repair. Ultimately, if inadequate carbohydrate intake continues, there is a shift to use body fat catabolism and protein for energy, resulting in weight loss and accumulation of ketones, especially if insulin is also limited. Essential fatty acid deficiency affects all cellular membranes and is particularly a problem with premature infants. DHA and EPA are long-chain omega-3 fatty acids that support retinal development, neurotransmitter production, and brain function. Vitamin and mineral deficiencies. Deficiency of vitamin C was one of the first recognized nutrient deficiency diseases, with the severe form called scurvy being a cause of death among early sea voyagers. British sailors were called limeys because their intake of limes while onboard sea vessels prevented this condition. In the early 20th century, processed grains were becoming popular. Soon, a mysterious syndrome appeared as the 4 Ds: dermatitis on sun-exposed areas, diarrhea, dementia, and death. This condition, pellagra, Pellagra, was determined to be from a B vitamin deficiency. The government mandated that processed white flour products had to be enriched with the nutrients that were removed during processing: vitamins B1, B2, and B3, thiamine, riboflavin, and niacin, respectively. The role of folate in the development of the central nervous system has been known for decades, but not until the 1990s did it become clear that most neural tube defects in the brain could be prevented by fortifying grains. Folic acid is now added to flour processed in the United States and in many countries, An important reduction in neural tube defects has been shown in these countries. Lutein and zeaxanthin are carotenoids found in yellow and orange foods, such as cantaloupe, corn, carrots, salmon, and egg yolks, that help to prevent macular degeneration, which is an eye disease. The intact form of vitamin A is also essential for vision. Deficiency begins with loss of night vision and progresses to total blindness. Vitamin D insufficiency is known to lead to osteoporosis, hip fracture, and hyperparathyroidism. Studies also suggest links with cardiovascular disease, cancer, multiple sclerosis, tuberculosis, and muscular and immune system disorders. Table 16.2 summarizes key nutrient deficiency and toxicity concerns. Looking at Table 16.1 on page 146, required nutrients, macronutrients, and primary role. Carbohydrates, protein, and fat are macronutrients. Carbohydrates are the primary source of fuel and energy. Protein facilitates growth and repair of tissues and is an energy source. Fat is a source of fatty acid necessary for growth and development and energy. Fat-soluble vitamins include A, D, E, and K. Water-soluble vitamins are vitamin C, B vitamins, which include thiamine, riboflavin, niacin, pyroxine, pantothenic, biotin, folate, and cobalamin. Major minerals are calcium, phosphorus, magnesium, sodium, potassium, and chloride. On Table 16.2, common vitamin and mineral deficiencies and toxicities. Nutrient vitamin A can cause night blindness, loss of appetite, bone pain, and hypercalcemia. Vitamin B1, thiamine, Wernicke's encephalopathy with neurodegeneration in the brain. Toxicity is rare to have too much. Vitamin B3 is pellagra with the 4 Ds, dermatitis, diarrhea, dementia, and death. Abnormal glucose metabolism. If you have too much, flushing, nausea, and vomiting. If you have too much vitamin A, you have loss of appetite, bone pain, and hypercalcemia. Vitamin B12 causes pernicious anemia if you have not enough. Psychiatric disorders as well. There's an unknown toxicity. Biotin, B-I-O-T-I-N, is deficiency is hair loss and toxicity unknown. Vitamin C can cause bleeding tendency and scurvy, and the consequences of too much is it inhibits zinc absorption and can cause urinary stones. Vitamin D, consequences of deficiency, rickets, bone disease, muscle pain, and falls. If you have too much vitamin D, you have hypercalcemia, renal stones, and calcification of soft tissues. Copper, not enough, causes anemia, skin lesions, neurologic disease, and bone fragility. Too much, Wilson's disease, neuron and liver cell damage. Iron, not enough, anemia, fatigue, poor growth. Too much is problems with the liver, pancreas, and cardiac damage. Magnesium, not enough, can cause hypertension, dysrhythmia, and preeclampsia, and too much can cause increased calcium excretion. Zinc, not enough, can cause dermatitis, impaired taste, impaired growth, low level of alkaline phosphatase enzyme. Too much can cause a copper deficiency, renal damage, nausea and vomiting, and diarrhea. Fatty acids affect cellular membranes. In premature infants, they could have neurologic and retinal development problems. Possible. Nutritional deficiencies. You can see this on this chart for the FDA for men requirements and the FDA for women requirements and the best source and the functions of each vitamin. Again, nutritional deficiencies are shown here for minerals, their function, deficiency associations, the adult dose range, food sources that you can obtain these from, and caution in regards to taking possibly too much. Nutritional excess. Malnutrition also occurs from excess macronutrient energy intake that leads to weight gain. Often, obese individuals may have micronutrient insufficiency, but macronutrient excess. The consequences of excessive weight have been well documented and can include type 2 diabetes, coronary heart disease, hypertension, stroke, fatty liver disease, gallbladder disorders, sleep apnea, asthma and other respiratory problems, musculoskeletal disorders, as well as some cancers. With more children and teens becoming obese, many of these medical conditions are seen at young ages with similar challenges and high risks for early mortality. MYPLATE.gov is the government's nutritional analysis and lets you know how much of your food intake is required each day, the 5 groups of food that should be consumed in the following proportions: 30% grains, of which half are preferably whole grains, 30% vegetables, 20% fruits, 20% protein, which are accompanied by low-fat, non-fat milk or other reduced fat dairy products. In review, choose MyPlate.gov. MyPlate is color-coded to show the 5 groups of foods that should be consumed each day in the following proportions: 30% grains, of which half are preferably whole grains, 30% vegetables, 20% fruits, 20% protein, which are accompanied by low-fat, non-fat milk or other reduced fat dairy products. Risk factors. All individuals have a potential risk for malnutrition. Some risk factors are common in population groups or during certain life stages, but individual choices and circumstances also have influence. Populations at risk. Age or life stage. At the beginning of life and again at the later stages, nutritional deficits are of significant concern. Pregnancy is a very important stage because of the long-term effects on health of the infant and the mother. The very young are at risk because of immature organ development and total dependence on others for feeding. Particularly at risk are premature infants because of impaired oral intake. With parenteral or tube feeding, the use of breast milk may be impossible, eliminating the benefits of cost savings, immunological protection, ideal nutrient content, and microbial support. Senior citizens are also at high risk for nutritional inadequacies. Factors such as reduced organ function, limited income, interactions between nutrients and medications, isolation, decreased interest in meal preparation, changes in appetite, fatigue, and altered taste sensations are common. Those elderly who are institutionalized are at even greater risk. Severe dietary restrictions, rigid meal times, generally poor health status, and feeding dependency can lead to inadequate oral intake. Physiological risk factors include frailty, low BMI, less than 21, is associated with a high risk of mortality despite nutritional intervention, and neurological defects from a stroke or Alzheimer's disease. Ethnicity and race. Nutritional deficits and genetic predispositions have triggered many chronic diseases of the modern world. Vitamin D deficiency is more frequently found among Hispanics and Americans of African heritage than those of European. Diseases more common in European heritage includes type 1 diabetes, celiac disease, and neurodegenerative disorders such as Huntington's disease and multiple sclerosis. The poor and underserved. As a population group, those of low socioeconomic status are at risk for malnutrition because of food insecurity and food availability. Lack of access to healthy foods because of insufficient funds, distance to supermarkets, limited options for food preparation, high prices of quality foods, cheap prices of fast food, and limited transportation are some of the reasons why individuals with low incomes may eat poorly and become obese. Whereas access to healthy, affordable food is limited, the community is designated as a food desert. Creative approaches are often needed to help families learn to budget their food dollars wisely and nutritiously. The homeless who experience food insecurity on a daily basis and over a prolonged period of time are particularly at risk. You can see box 15.2 in Fundamentals TIMB, page 294, Nutrition and Weight Status Objectives for Healthy People 2020. Healthier food access is one of their goals. Increase the number of states with nutrition standards for foods and beverages provided to preschool-aged children in childcare. Increase the proportion of schools that offer nutritious foods and beverages outside of school meals. Increase the number of states that have state-level policies that incentivize food retail outlets to provide foods that are encouraged by the USDA's dietary guidelines for Americans. Increase the proportion of Americans that have access to a food retail outlet that sells a variety of foods that are encouraged by the USDA's dietary guidelines. Healthcare and work site settings. Increase the proportion of primary care physicians who regularly measure the body mass index of their patients. Increase the proportion of physician office visits that include counseling or education related to nutrition or weight. Increase the proportion of work sites that offer nutrition or weight management classes or counseling. Reduce the proportion of children and adolescents who are considered obese. Prevent inappropriate weight gain in youth and adults. Food insecurity. Eliminate very low food security, a state in which people have access at all times to sufficient, safe, nutritious food to maintain a healthy and active life among children and adults. Reduce household food insecurity, and in doing so, reduce hunger. Food and nutrient consumption. Increase the contribution of fruits to the diets of the population aged 2 and older. Increase the variety of vegetables to the diets of the population aged 2 and older. Increase the contribution of whole grains to the diets of the population aged 2 and older. Reduce consumption of calories from solid fats and added sugars in the population aged 2 and older. Reduce consumption of saturated fat in the population aged 2 and older. Reduce consumption of sodium in the same population, and increase consumption of calcium in the same population. Iron deficiency. Reduce iron deficiency among children, young children and females of childbearing age. Reduce iron deficiency among pregnant females. Factors that influence nutritional needs continued. Personal food choices. Personal choice is a major internal influence over food intake. Women tend to experience cravings around their menstrual periods and during pregnancy. If they give in to these cravings regularly, obesity may result. Occasionally, individuals may experience nutritional disorders because of erroneous understandings or perceptions about food. If a vegan diet is undertaken without adequate knowledge, the intake may be insufficient for essential amino acids, calcium, zinc, and vitamins D and B12. Inadequate vitamin B12 has been associated with anemia and with neurologic damage, especially dangerous in children. Calcium and vitamin D levels tend to be low unless fortified foods or supplements are used. Without adequate planning of foods containing the various amino acids, protein deficiency can occur. Fortunately, a carefully planned vegan diet offers protection against obesity, hypertension, type 2 diabetes, and cardiovascular disease, especially in men. Individual risk factors, genetics. Many conditions that impact nutrition are linked to genetics. Inherited metabolic defects include phenylketonuria, called PKU, a deficiency in the enzyme responsible for the metabolism of the amino acid phenylalanine. PKU allows phenylalanine to accumulate in the brain, blood, and tissues, leading to cognitive dysfunction unless the affected individual follows a low phenylalanine diet for life. Other rare inherited metabolic defects include galactosemia and maple syrup urine disease. In cystic fibrosis, thick secretions block pancreatic ducts, eventually lead to impaired digestion and absorption of fats and fat-soluble vitamins. Lifestyle and patterns of eating. How one chooses food, shops, plans, and prepares meals ultimately affects his or her nutritional status. Factors that influence these decisions include interpersonal relationships, learned stress coping mechanisms, and alterations in mood. Weight gain can occur when food habits change to match those of the partner, such as during dating and marriage. Family food offerings can positively or negatively influence nutritional intake. Mothers who avoid high-fat, high-sugar foods but emphasize a variety of vegetables, fruits, whole grains, lean meats, and low-fat milk can send the right message to their family, as well as fathers. Family influences that may negatively impact nutritional status include lack of home-prepared meals, eating meals on the go, restricting multiple food groups because of allergies or dislikes, or limited choices because of financial challenges and access to good food. The influence of peers is common among adolescents, skipping meals, following fad diets, choosing salty and sugary snacks over healthy foods, eating supersized portions, and drinking alcohol are examples. Here, mood swings dominate. Coping mechanisms often include eating large amounts of sweet or comfort foods or reducing intake altogether during periods of depression. Peer influences are especially strong among young people with lower self-esteem. Underlying medical conditions. A wide range of medical conditions place individuals at risk for various nutritional problems. Impaired oral intake. Adequacy of oral intake is associated with the ability to chew and swallow. The inability to chew or swallow properly can easily lead to malnutrition. Pain from dental caries, caries, which means cavities, poorly fitting dentures, and loss of teeth can impair the ability to chew and limit diet quality. Cleft palate impacts an infant's sucking ability, thereby limiting successful breastfeeding. Difficulty swallowing, called dysphagia, dysphagia, is common in neurologic conditions, especially after a stroke. Not all patients require altered food consistency, but patients should be seated as upright as possible in a high Fowler's position to prevent aspiration. In conditions such as Parkinson's or Alzheimer's, the sense of smell diminishes, also leading to decreased food intake. Unbalanced food intake also occurs in mental health conditions such as anorexia nervosa, mood disorders, anxiety, and depression. Impaired digestion and absorption. Many conditions interfere with digestion or absorption and place the affected individual at risk for malnutrition. Examples of such conditions include lactase intolerance, gastroparesis, gastric surgery, intestinal resection, and inadequate gastric acidity. Some genetic conditions lead to defects in metabolism of nutrients such as PKU, mentioned previously. Impaired digestion and absorption can occur as an adverse effect from some medications. Increased metabolic demand. A variety of conditions increase metabolic rate and energy needs, thus increasing the risk for protein-calorie malnutrition. Examples include cancer, chronic obstructive pulmonary disease, Parkinson's disease, trauma, including burns, stroke, and HIV/AIDS. Depending on the severity of the disease state, it may be difficult to meet the increased nutrient needs without enteral or parenteral nutritional support. Altered organ function. The failure of organs involved in digestion and metabolism are associated with nutritional deficiencies. Hepatic or liver disease adversely impacts the ability to reassemble amino acids into the various proteins needed for physiological function. A damaged liver will also be unable to metabolize and excrete drugs properly, thus altering nutrient absorption and utilization even further. In chronic kidney disease, abbreviated capital CKD, nutritional status is adversely impacted through a variety of mechanisms. Protein is lost through the urine and can lead to impaired skin integrity, slow wound healing, suppressed immunity, sarcopenia, and altered osmotic pressure. As chronic kidney disease progresses, phosphorus levels can increase and lead to hypocalcemia, low calcium. Renal disease further reduces nutrient levels, especially vitamin D, because the kidney metabolizes vitamin D2 into the bioactive D3 form. With lowered vitamin D status, bone health is impacted because vitamin D is required to absorb calcium for the bones. The kidneys are involved in producing red blood cells. Therefore, in patients with chronic kidney disease, anemia can develop that is unresponsive to iron intake due to an insufficient level of erythropoietin, a protein-based hormone. Even nutritional therapy can have adverse nutritional consequences. Limited fluid or food intake and phosphorus, protein, potassium restrictions can be challenging. This is especially true when chronic kidney disease is compounded by an acute illness. Thus, organ damage and illnesses can seriously impact nutritional status, as shown in Table 16.3. Again, factors that influence nutritional needs: food preferences, established patterns for meals, attitudes about nutrition, knowledge of nutrition, income level, access to good foods, and time available. Also, the number of people in the household affects nutritional needs. Assessment. All nurses should know how to perform a basic assessment of nutritional status. Maintaining an awareness of the risk factors helps to focus the interview and examination. History. In the interview of the patient or family members, it should be remembered that food has a strong emotional component. Actual food or eating practices may not be revealed unless there is trust and rapport. This is especially true when interviewing parents of a child whose growth and development are not within expected ranges. Generally, adults respond more openly to health providers if they are aware of the rationale for the questions. Mentioning some potential nutritional complications of a condition or asking about the individual's personal health concerns allows for focused interviewing. The basic elements of a history include nutritional intake, diet restrictions, changes in appetite and intake, changes in weight, medical history, current medical condition, current medications and treatments, allergies, family history, and social history. In addition, it's important to consider the chief complaint presenting symptoms because they might relate to nutrition and may warrant a symptom analysis. The most important screening problems or presenting symptoms include the following: unplanned changes in weight, changes in appetite or intake, nausea and/or vomiting, difficulty chewing or swallowing, abdominal pain or discomfort, changes in bowel habits, and recent history of constipation or diarrhea. Examination findings. Several techniques are used to assess nutritional status, including general observation, anthropometric measurements, and other various clinical findings from systems assessment. Measuring height and weight and determining body mass index are the initial steps in assessing nutritional status. General goals and interpretation guidelines for BMI are presented in Table 16.4 in concepts. If BMI is within normal limits and weight has been stable, it is still important to have at least a brief assessment of oral intake to verify that macronutrients and micronutrients are being consumed in appropriate amounts. If there is any suspicion of poor nutritional status, lab work should be ordered by the attending provider to help assess status more completely. General physical appearance, level of orientation, and demeanor will give insight into health and nutritional status. Assess skin integrity and turgor. The skin should be smooth and elastic without cracks or bruising. The hair should be shiny and not brittle. Nail beds should be smooth, pink, and firm. The teeth should be free of cavities, and the oral tissues should be moist, pink, and firm. Mucous membranes around the eyes should be pink, moist, and free of lesions. The sclera should be white. The cornea should be clear and shiny. And there are differences in people of color. You should note that the sclera in the eyes sometimes have some yellow to them, and that does not mean that they have hepatitis or that they have liver disease. Also, the condition or color of the nails may look a little differently, but the idea being that they should be smooth and not brittle and without cracks. And the oral mucous membranes also maybe look a little differently in people of color. So just be sure to educate yourself on this. Diagnostic tests. Nurses need to understand common nutritional related tests, and they need to know when to alert the physician or dietitian if malnutrition is suspected. Laboratory test: serum albumin and prealbumin. Serum albumin measures circulating protein in the blood. Low albumin can reflect protein-calorie malnutrition. However, other conditions such as inflammation, blood loss, and fluid status can cause low serum albumin levels. Low albumin levels predict severity of illness and are also predictors of mortality in adults older than 60 years. Prealbumin reflects recent dietary protein intake. Low prealbumin is generally associated with nutritional intake as opposed to other conditions. Blood glucose and hemoglobin A1C. Blood glucose reflects metabolism of carbohydrates, and this test is generally used to screen or monitor for impaired glucose metabolism. Hypoglycemia may suggest inadequate caloric intake, and hyperglycemia may be an indication of diabetes mellitus. Hemoglobin A1C is a test that shows average blood glucose levels over time period of at least several months and is used in the management of diabetic patients. It indicates how well glucose levels are controlled. Note that for anemia or renal disease, false readings of the A1C level may occur. For this reason, fingerstick glucose tests may be preferable in these situations. Lipid profile. A lipid profile includes several tests that assess lipid metabolism and serve as important indicators of risk for cardiovascular disease. Tests included are low-density lipoprotein, LDL, high-density lipoprotein, HDL, cholesterol, and triglycerides. Triglyceride levels generally reflect hyperinsulinemia, although in an individual with newly diagnosed type 1 diabetes may have temporary elevations of triglycerides. Electrolytes. Electrolytes provide information about general health status, including specific information about micronutrients, including sodium, potassium, calcium, magnesium, and phosphorus. These are usually ordered as part of a chemistry profile blood test. Electrolytes can become imbalanced with inadequate dietary intake or many other conditions such as kidney, renal disease, liver disease, and diabetes. See the fluid and electrolytes concept in Concepts for further information. Hemoglobin and hematocrit. Hemoglobin, HGB, and hematocrit, HCT, is a blood test that examines red blood cells, including the number, size, shape, and color, to diagnose anemia caused by dietary deficiencies such as iron, folate, and vitamin B12. Hemoglobin and hematocrit also provide information about the hydration status of the patient. Radiographic scans include DEXA scan. DEXA scan usually assesses or measures bone density. It may also have uses in determining body composition, such as percentage of lean muscle and fat. The dual energy X-ray DEXA scan uses two low-energy X-ray beams, which doctors direct toward the bones. T-score. The number shows the amount of bone you have compared with a young adult of the same gender with peak bone mass. A score of 1 and above is considered normal. A score between negative 1.1 and negative 2.4 is classified as osteopenia, which is low bone mass. And a score of negative 2.5 and below is defined as osteoporosis. Clinical management. Primary prevention. Primary prevention measures are aimed at preventing the onset of disease through risk reduction and behavior modification. The foundation of primary prevention efforts as it relates to this concept includes healthy eating and physical activity. Healthy eating. A person who follows the current dietary guidelines for Americans in MyPlate, see choosemyplate.gov, can achieve a healthy diet. The inclusion of the minimum number of servings in MyPlate will meet the daily requirements of micronutrient and macronutrient needs for general health needs. The dietary guidelines are aimed more at preventing chronic health disease associated with excess intake of macronutrients, especially solid fats, saturated trans fats, sugar, and salt. Food labels with DRI values reinforce the dietary guidelines. Food labels also state four marker nutrients: calcium, iron, vitamin A, and vitamin C. Generally, if these micronutrients are included in adequate amounts from foods naturally high in them, the other needed micronutrients will also be obtained. Breastfeeding is recommended for optimal nutrition of infants for the first 4 to 6 months of life. Breast milk contains all the essential nutrients and has immunologic benefits that protect the infant from acute and chronic disease. Physical activity. Physical activity helps to prevent obesity. The general goals include 30 minutes of physical activity on most days of the week or 150 or more minutes weekly. Weight loss may require at least twice this amount of exercise. However, guidelines for exercise need to be individualized. A sedentary person or one who has sarcopenia or cardiovascular disease needs limited time intervals of exercise more frequently. Secondary prevention involves screening tests to detect disease. Screening for nutritional status in the general population is limited primarily to lipid screening, blood glucose screening, and BMI. Blood glucose screening is advised for persons with evidence of insulin resistance, such as central obesity found with metabolic syndrome. Lipid screening is also recommended, particularly for those with specific risk factors. Although not an essential nutrient, it often becomes necessary to supplement coenzyme Q10 with long-term statin use. And statins bring your bad cholesterol down. For infants, routine screening that occurs at birth includes the following: glucose levels, at least 40 different genetically linked metabolic disorders, including PKU and maple syrup urine disease, that are related to an inability to metabolize certain amino acids or to errors in fatty acid metabolism, carbohydrate disorders, including galactosemia, other congenital disorders that can affect nutritional status, including cystic fibrosis and HIV. The number of screenings will vary from state to state. Hospital diets. Some common hospital diets include the following: regular or general, which allows unrestricted food selections; light or convalescent, differs from regular diet in preparation, typically leaves out fried, fatty, gas-forming, and raw foods and rich pastries. Soft diet contains foods soft in texture, is usually low in residue and readily digestible, contains few or no spices or condiments, provides fewer fruits, vegetables, or meats than a light diet. Mechanical soft resembles a light diet but is used for clients with chewing difficulties, provides cooked fruits and vegetables and ground meats. Full liquid contains fruit and vegetable juices, creamed or blended soups, milk, ice cream, yogurt without bits of fruit, pudding, milkshakes, gelatin, junket, custards, and cooked cereals. Clear liquid consists of items that may be colored but are generally transparent and do not contain any pulp or bits of food. Examples include water, broth, fruit juices, flavored gelatin, popsicles, clear soft drinks, tea, and coffee. Special therapeutic consists of foods prepared to meet special needs such as low in sodium, fat, calories, or fiber. Most healthcare agencies have a dietitian who plans the meals and a centralized food service that prepares clients' meals. Nurses are generally responsible for ordering and canceling diets for clients, serving and collecting meal trays, helping clients to eat, and recording the percentage of food that clients eat. Nurses must know the type of diet prescribed for each client, the purpose for the diet, and its characteristics. They take care to ensure that clients receive the correct diet and that restricted foods are withheld. In review, soft contains food soft in texture, usually low in residue, which is fiber, and readily digestible, provides fewer fruits, vegetables, or meats than a light diet. Mechanical soft resembles a light diet, but used for clients with chewing difficulties, provides cooked fruits and vegetables and ground meats. Continue to review. Full liquid diets are fruit and vegetable juices, creamed or blended soups, milk, ices, ice cream, gelatin, junket, custards, and cooked cereals. Clear liquid is water, clear broth, clear fruit juices, plain gelatin, tea, and coffee. May or may not include carbonated beverages. Special therapeutic foods are meant to meet special needs such as low in sodium, fat, or fiber. In review again, secondary prevention is screening at birth for genetically linked metabolic disorders such as PKU, phenylketonuria, maple syrup urine disease, cystic fibrosis. Glucose screening is used for also for infants, and screening for adults technically usually involve lipids, body mass index measurements, and electrolytes. Collaborative interventions. There are several interventions for nurses to manage individuals who have nutritional related health conditions. Interventions are classified into the following major groups: dietary interventions, pharmacologic agents, and surgical interventions. Coordination of care often involves working with a registered dietitian nutritionist, with home care services, or with the community agencies such as a referral to Meals on Wheels for home delivered meal services. Discharge planning is an essential team effort on behalf of the patient. Dietary interventions. As part of the healthcare team, nurses often work with other health professionals for optimal nutritional outcomes. Registered dietitian nutritionists, called RDNs, are health professionals who have a background in biochemistry and metabolism, with knowledge about the macronutrient and micronutrient contents of food and how the body uses them. Another health professional, the dietetic technician, assists the RDN with menu planning, nutrition education, and management of food services. Nutrition therapy is a term used to describe the typical services of the RDN, or registered dietetic technician, whereas medical nutrition therapy is a legal term for reimbursable services provided by the RDN. The nutrition care process includes standardized language and codes within the profession of dietetics. Complex assessments, nutrition diagnosing, and diet therapy interventions are the role of the RDN. A qualified RDN may have diet order writing privileges as determined by competency assessment, licensure laws, and facility protocols. Thus, the RDN can adjust a patient's meal plan so that it is appropriate for health goals, realistic, economical, and feasible for the family. Nurses should understand basic modified diets to reinforce messages provided by the RDN and encourage referrals as needed. The concept of personalized nutrition is replacing the old paradigm that one diet fits all through the science of nutrigenomics. In other words, how genetics influence nutritional intervention. Individuals differ in how nutrients are assimilated, metabolized, stored, and excreted. These differences are often significant. Further individualized dietary plans are needed to address unique dietary needs of patients based on their age, calorie needs, and underlying health condition. For example, not all hypertensive individuals respond to sodium salt restriction. Not all individuals with high serum cholesterol levels respond to a low saturated fat diet, and sugar alone is not the culprit in diabetes management. Another aspect of dietary interventions is ensuring that the food provided matches the patient's ability to eat. A patient who has his or her original teeth, none missing, and good oral hygiene or well-fitting dentures and adequate saliva represent the best scenario for chewing of all kinds of foods. Unfortunately, many hospitalized or aging patients require assistance because they have missing teeth or dentures, or because their dentures no longer fit. Nurses can make notes of these concerns early in treatment so that altered diets may be ordered or oral health services can be provided. Enteral nutrition. Nurses administer nutritional support via tube feedings. Tube feedings are indicated for an individual who is unable to eat or swallow but has an intact functional GI tract. Feeding tubes are inserted directly into the stomach or small intestine for the delivery of enteral feeding, ENTERAL. A specific formula is selected by the physician and RDN based on patient needs. In some hospitals, RDN may be qualified to write the diet orders or even to insert the tube. The tube feeding is administered either by gravity or through a feeding pump. A common form of tube feeding is percutaneous endoscopy gastrostomy, which is a PEG feeding. A PEG tube requires a small incision into the stomach. Fortunately, the procedure is relatively safe, simple, and reversible. Although unused formula must be discarded after 24 hours, the tubes can be maintained longer with strict infection control procedures according to the facility's protocol. Parenteral nutrition. Parenteral nutrition is used to provide either total or supplemental nutrition intravenously. These intravenous feedings are generally used for patients who have intestinal failure and cannot be fed orally or by enteral feeding. Here, nutrition consists of a glucose-based intravenous solution, with various dextrose concentrations, with electrolytes, minerals, and amino acids. Fat emulsions lipids may also be included or administered as a separate solution. Because parenteral nutrition is indicated for individuals who are unable to process nutrients via the GI tract for more than 4 or 5 days, therapy can be short-term or long-term. For short-term, it may be administered peripherally, whereas for long-term, it can be administered centrally through a central line. Sepsis and electrolyte and metabolic imbalances can occur, so meticulous nursing care of the vascular access is required. Excessive infusion of enteral or parenteral nutrition solutions can be dangerous. The critically ill patient is vulnerable because metabolic shifts occur throughout the day from sepsis and various procedures. Ideally, indirect calorimetry is used to determine energy needs so overfeeding can be avoided. Extra caution should be used in pediatric and neonatal units. Surgical interventions. The most common surgical intervention affecting nutrition is bariatric surgery. It is increasingly being used to control obesity and diabetes. Generally, bariatric surgery has demonstrated good success for weight loss, improved glucose level, and normalized blood pressure. However, complications include macro and micronutrient deficiencies that are not easily managed, either because of lack of adherence to dietary and supplement guidelines or because of limited knowledge of actual needs. In addition, weight gain can still occur if the patient is non-compliant with calorie control. The most malabsorptive bariatric surgical procedure is the Roux-en-Y gastric bypass. In this procedure, most of the stomach and the proximal small intestine are bypassed, with food entering a Y-shaped reconnection between the upper stomach and the distal portion of the duodenum or jejunum. Lap band procedures are much less invasive, although nutritional deficits are still possible. Pharmacological agents. A number of supplements are used to enhance the nutritional status of individuals, and most are available over the counter. Supplement examples include vitamin supplements such as multivitamins, niacin, B vitamins, and vitamin C, mineral supplements such as iron and calcium and folic acid, and protein and nutrient supplements such as Ensure, nutrition bars, etc. In regards to pharmacologic agents for obesity management, research continues. There have been complications with previous forms of weight loss medications, and currently all these medications have limitations on duration of use. Statins, atorvastatin, fluvastatin, lovastatin, pravastatin, and rosuvastatin are the drugs of choice for treatment of lipid and cholesterol reduction because of their ability to inhibit the synthesis of cholesterol, leading to reductions in LDL and HDL. There are a variety of pharmacologic agents that address other nutrient-based problems, including dietary supplements, statins to control lipid levels, and agents to control glucose levels. Question. The process of mechanical and chemical breakdown of food matter and complex forms of macronutrients is called 1. Cellular metabolism, 2. Absorption, 3. Elimination, or 4. Digestion. Your answer should be cellular metabolism. The diagnostic test, next question, the diagnostic test that helps identify bone integrity is called 1. Dual energy X-ray absorptiometry, which is called the DEXA scan, body mass index, erythrocyte sedimentation rate, or radioactive bone scan. And your answer should be 1. Dual energy X-ray, the DEXA scan, DXA. Question. What is the most common surgical intervention affecting nutritional status? Is it colon surgery, esophageal surgery, bariatric surgery, or oral surgery? And your answer should be bariatric surgery, number 3. This is the end of the slideshow.